and you're not going to let them have anything by mouth. With a real significant case where they have to be hospitalized.
Can those pouches close up eventually?
No.
Ooh.
No. I mean, that's damage done. But what you must have to do is you must follow a very specific type of diet. It's going to be making sure that you don't be taking in the seeded kinds of foods, because seeds can actually scrape and cause flare-ups. They would tell you no tomatoes, because why? Those tomatoes actually have seeds. My father-in-law has recurrent bouts, and the doctor says, don't eat tomatoes. That's just one vegetable, seeded things. And he loves to grow tomatoes in his garden. And he's 81, and my husband will call him and say, well, what'd you have for lunch today? Oh, I had a tomato sandwich. So I said, you gotta, but you know, what can you do? Right.
Yeah.
Life's too short. But you rest the bowel. There's antibiotic therapy, because obviously these little things have become infected with, you know, how it could get trappings in those little pockets, right? And then the worst case scenario would be where they would have to cut and excise and remove part of the colon. Now we have so much, I think it's, can't recall, but it's almost like small intestine has 27 feet or 30 some feet, and then the large intestine has about 3 or 4 feet, right? We have lots to work with here that we can do some surgical maneuvers. However, I will tell you there have been some situations where it has run the whole gamut of the large intestine, and that's a serious situation. Bowel diversions. When I'm talking about bowel diversions, and this segues nicely into the concept about the diverticulosis, because maybe they might have to do these types of bowel diversions where this patient will ensue like a colostomy or ileostomy, and it comes out to the surface, right? Some of you guys in my group have seen patients at the autumn winds that have colostomy. Some of you guys have it. Oakwell, y'all going to Oakwells? I'm not sure where everybody's going.
Yeah, well.
Yeah. But these are just some, they may be temporary, they may be permanent. And they bring out through the surface as a surgical maneuver for whatever reason they've had to remove part of the, because it could be, they might have exhibited some cancer and they've had to excise, right? Those kinds of things. So you have different kinds of procedures for the ileostomy and the colostomy. And that's just one example. But just look at your pages I've identified that talk about colostomy and ileostomy for more understanding. So when we consider our focused assessment, our nursing history, we need to ask the questions. What is your normal bowel pattern? Could each and every one of you know what your spouse's normal bowel pattern is? Would you be able to tell a doctor?
Nope.
See, we need to be, so you see what I'm saying? We need to know these things, because maybe they, see what I mean? It's important.
And my
How
daughter's
many
just a light.
BMs do they have in a day? It's important. And you need to tell your spouse likewise. This stuff, people think, oh, it's just too much, but it's not. This, I'm telling you, bowel elimination is one of the worst problems that we have with hospitalized patients. It really is. Why do you think we're trying to get patients up post-surgery pretty immediate? It's not just to ward off the atelectasis pneumonia. It's to wake up the bowel system too. You know, they'll say, well, we want to make sure we don't get atelectasis in our lungs, you know, post-op pneumonia. But it's not just all about that. You want to talk to your spouse. So if I use your spouse, maybe it's a personal thing, see? But see, you want to do this with your patients. What's the normal appearance of your stool? Have you had a change in your bowel habits or stool appearance lately? Do you have a history of elimination problems? Well, sometimes I get constipated. You know, I have this odd skin formation on my rectum.
Oh, here's that.
I mean, if you don't ask, are they going to tell you? I don't think so. They're embarrassed. Y'all would be embarrassed. I'm not embarrassed. After about 27 years, I'm not embarrassed anymore in nursing. I've seen it all. What types of bowel elimination aids, diet, and exercise medications do they use? Because let me tell you, these older people that's been dealing with problems for years and years and years, we find that these individuals, they've been embarrassed for all these years. They would not dare tell their doctor, that's too embarrassing, right? Y'all got to picture that. So what they've done is they've used these over-the-counter aids, X-Lax. And you know what that does? Because, you know, you got to think of the bowel being a muscle. We've weakened the muscle. Because, you know, to bear down, to have a bowel movement, sometimes it's a lot of effort, right? Where they say, push, 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 having a baby, right? I mean, it's sort of symbolic like that, right? But these, well, you know, because what happens is these older adults, they've been on this laxative therapy for years and years and years and years. And now they do not have the abilities to have a stool because their muscle has atrophied to where it's just flabby nothingness. So it's a big issue. I worked with this GI doctor for many years, and he would always say it's very important that you tell your patients not to be taken in the X-Lax, the ones that you can put into your mouth and work that way, right? A laxative that way. But rather, if they need to have some sort of laxative and it's not contraindicated, suppository, glycerin suppositories, it's not contraindicated, that Fleet's enema. Because the thing is you don't want to make your bowel lazy. You know, as we get older, we slow down in our activity. And that's one thing that can happen. But we found that many a time where the elderly person, and not realizing they were doing harm to themselves, has very poor bowel function because they let that atrophy. Because they just, you know, these over-the-counter miracle things, right? They worked when they were younger, but now, you know, gotten older and there's no muscle there to help with the movement, the peristalsis. Okay, so when we assess the abdomen, what do we do first? We inspect, don't we? We pull up the gown and look at the abdomen. Now, how can you inspect if you don't pull up the gown? So now I'm giving you a heads up in health assessment course for next quarter, because all of you's gonna make it, right? Yes. You're gonna make sure everybody makes it. You've got to pull up the gown and look. You've got to pull up the gown and look. Inspect first. Inspect. I say after inspection, auscultate. And then they have this palpate percuss thing. And those can get a little bit tricky. But the most important thing is suspect and then auscultate. And be systematic when you auscultate. Do a quarter your abdomen, imaginary quarter. And this provides you an example. But even within this, in each quarter, you could maybe choose 3 different, like a triangulation in each quadrant. See? Listen for at least 3 to 5 minutes. I think that's what your book says. If you hear a gurgle, you move on, right? Because you've only got 8 more patients to assess. If you hear one gurgle in that quadrant, move on to the next quadrant. Because time's short, right?
Yep.
You have different types of vowel sound pitches. Some of you guys got to hear that machine, Miss Algazay, when you were doing the health assessment. Did y'all get to listen, the upright body?
Sims.
Sim, right, and it actually has vowel sounds. I mean, it might not be the greatest because it seemed like it was like knocking sounds, like that, But it was giving you the symbolic concept, the gurgling sounds. You have different sounds, normal, and it's 5 to 15 approximately. Hyperactive is very high pitched, more frequent than the normal. And those you might actually associate with some sort of small bowel obstruction or some sort of inflammatory process. Low hypoactive, those are lower pitch. Hypoactive, lower pitch, and infrequent. What we may hear a lot with individuals undergoing or having constipation. And of course the absent vowel sounds. Nothing. I hear nothing. The person that's a fresh post-op. And if you have an NG tube in for low wall suction, you would keep that off. Yes, you would keep that off when you're listening. Because if you don't, it has this low intermittent wall suction, and you might think that suction depicts a sound of a vowel sound, and it's not. So make sure you always crinkle that tubing when you're listening to the vowels. Question.
Would you always hear vowel sounds unless they have 8 vowels?
Oh, no.
Would they stop?
The same part.
Yeah.
So how do you know those each for a while?
Oh, no. You're going to have something, if they have normal bowel function, you guys that don't eat for 8 hours, your gut's roaring, isn't it? A lot of times. Try the experiment. Don't eat for 8 hours.
Oh, I did that already.
Oh, you were already having this experiment.
So, okay, I'm trying to.
You learned it in the PD Sims just because your body, your stomach hurting, that don't mean you're hungry, it's because your
Yeah,
stomach
it
is
wouldn't,
moving.
because you had a lot of irritation, some sort of irritation going on with your
It's
system.
time to get
When
released.
I was sick, I listened to it because it was hurting, so I wanted to
Can
know
you
what
share
it
with the
was.
class what we're talking about? Do you have a problem with that?
No, I don't.
Can, okay, and you're Jennifer, Michelle, yes, Michelle. I'm sorry, I've got to learn you guys. Please share,
Time to go,
because
Reverend.
she's had some unusual, and it ties right into this chapter, and then we'll take our break, because she'll want to.
Well, nothing, actually, I have an endoscopy.
And what do they do? So, tell them what endoscopy. Tell them what
Endoscopy.
happened.
An endoscopy is like a camera that goes down your throat, looks in your whole intestines, and this looks in your stomach and looks for ulcers or erosion or anything like that, which I have none, so I just call it my phantom pain, but it's just, I don't
Did they find no?
they didn't find anything actually, I just had some random pains, and they thought it was a lot of different GI problems.
Yeah.
Because my stomach was making a lot of noise, and then I told them it hurt.
They're
where it
different
was,
though.
in the same
They're
area,
putting the
so they all
vasodilators
seemed
over
good.
here.
They were actually quite surprised
And
from
then
like
they're
the pain I was in, and that there's something wrong.
Because these bring
So now
beta,
you're back on,
calcium.
are they advancing you
all
with
those books in
clear liquids, or have you already gone for
No,
clear?
they
the
just told me to
calcium.
do a really clean diet just to make sure, because they want to make sure it's not a
The
GI
calcium,
problem.
Yeah.
no
It could
blood.
be something, they wanted to do a couple different tests, but
That's
he
why
didn't
I
know what
put
it was
it
exactly.
different.
So
Yeah.
he said, we can go a
Because they
bunch
got
of the
different
tests,
fibers.
but, you know, I don't know what
It's
for.
so convenient.
Yeah.
It is. I was
She had an upper
kidding.
Yeah, I didn't.
endoscopy, not a colonoscopy, but an endoscopy. Okay, so let's take any questions, do you have any questions though for her, for
My
Michelle?
brother had that too, and they did actually go through it.
The colonoscopy